eShadowing session. It is my pleasure to introduce our physician for today, Dr. Hayley Bourne. She's a doctor specializing in otolaryngology, and today she will be sharing with us her journey from medicine to her specialty. And with that being said, Dr. Hayley, whenever you're ready to start.
Hi, everyone. I'm super excited to talk to you a little bit about how I got to where I am and hopefully be able to answer any questions that you guys might have. I am not only an otolaryngologist, which is the long, complicated way to say ENT, but I am subspecializing in what's called laryngology. So I'll get a little bit more into that later. But it's just to say that medicine has become hyper specialized, and you can take a 1-inch area of the body and make that your entire specialty, which is pretty cool. So I went off of the guide that they had given me as far as how to sort of discuss how I got to where I am. And I sort of wanted to take it from the beginning. And for me, that started in high school. I'm from a small town in Wisconsin, and I actually had my first introduction into medicine as a kid because my dad was actually a doctor. But mostly that meant for me that sometimes he would record over our VHS tapes with surgery videos, and it would be a rude awakening when we went to go and watch our kid videos, and we'd see eyeballs because he was an ophthalmologist. But then I became much more intimately familiar with medicine in the middle of high school. I was actually diagnosed with lymphoma and experienced medicine from the other side as a patient. And the beginning of that whole process actually began with an appointment with an ENT. And for me, that sort of put it on my radar as a specialty within medicine. So I always knew medicine was a thing because of my dad. And then I knew ENT was a thing because I had met one very in a very familiar way. So learning about medicine from both sides of the coin, I think, is super valuable. And you can really draw from those experiences either as a patient or as a caregiver, and keeping that in mind throughout the process of deciding whether to go into medicine, and then also the training that's involved in medicine is really important because it gives you a perspective that you might not have otherwise. Um, Experiences that I did during high school, I actually did work within the medical community a little bit. I worked in a pharmacy and I volunteered in the hospital, did some shadowing opportunities just early on, knowing that I might end up in the medical field. So I started pretty early, but that's not to say that you have to. I actually went out east for undergrad. I went to Yale. And when I was at Yale, it was a process of deciding what my major was going to be, which I'm sure all of you are probably going through right now. I ended up choosing very boring to be a biology major, so molecular, cellular, developmental biology. And the reason I did that wasn't so much because all of my interests lied in biology and there was nothing else that I wanted to do. It was more that the major overlapped with the requirements that I had for medical school applications. So I chose my major based on having an idea that I would probably at least think about going to medical school. And that way I had time with my other credits that were outside of my major to do more fun things like basic drawing. And I took a really neat class about the hero in the ancient Near East and ancient Mesopotamia. And, it gave me a little more flexibility with my other credits. So I think that that's something that a lot of people don't think about. You want to set yourself apart and try to be an English major or an art major, something different other than biology or chemistry. But it can make it very convenient when all of your pre-med prerequisites also fall under your major. So that's one thing to keep in mind when you're choosing your major. And if you're thinking about doing medicine, is to sort of optimize the efficiency of what you're required to do so that you can do things that are fun and interesting to you as well. A big part about the medical school application process is obviously the Mcat. I don't really remember a lot about the MCAT other than that I spent one spring break on campus studying and I did one of those review courses and probably had way too much anxiety about it in general. But obviously, we all know that standardized tests play a big role in the admissions process. What I would say, and I'll talk about this a little bit more later, for the match, but I would say that it's important to remember that your application can stand out for reasons other than just your test scores. So, having a relationship with somebody who's willing to reach out on your behalf to a medical school that you're interested in, or doing a research project that you're really excited about, having a leadership position that you really are passionate about and therefore do a really good job at, all those things can make your application stand out more than just a test score. So I think that a bad test score can be overcome, and also a good test score isn't going to guarantee that you're going to get to go wherever you want. So you got to make sure that you're focusing on being a well-rounded person, both for your own sanity and also for the process of applying. If you focus only on getting into medical school, it's going to make you very boring to talk to, and also for your own sanity, you want to find other things that you're passionate about, and that shines through during the application process. I'm sure you guys have heard all of that advice before, but just sort of my own little pearls. And you'll forget, I don't even remember how many points the MCAT is out of anymore. So nobody cares what you got on your MCAT once you get into medical school. So I wouldn't worry too much about it. I ended up going to Columbia in New York for my medical school. And that was a complicated choice for me. Most of my friends from Yale were going straight to New York. About a third of our class was just going just down the road, I guess you would say, from New Haven to New York. So that was a comfort to have a community. But I think that choosing a medical school is a lot about fit. So if you are lucky enough to have a choice for where you go, don't necessarily choose based on the most prestigious or the most highly ranked. That being said, it is helpful going forward in your career if you go, it's just like anything else. If you go to a good undergrad, it shows a certain level of drive and achievement, and then it can make it easier for the next steps. But it's not the be all and end all. And you're much better off going someplace where you're going to be happy and productive than going someplace that's going to look good on a resume. Because if you're not happy and you're not engaged, then you're just not going to want to succeed. You're not going to succeed going forward. I had a bit of a circuitous medical school route in that we took step one very early in our medical school career. So we only did a year and a half of preclinical education for our curriculum, which I think is becoming more and more widely used as a pattern. It used to be 2 years preclinical, 2 years clinical for everybody. And now a lot of places are shortening the preclinical classroom didactic part of medical school, which I think is good. And for me, that meant that we took our step one of our USMLE board exams, which is part of the process for applying to the next step. There's always a next step. And we took that very early. I also started my clinical rotations early, and I was lucky because one of my first rotations actually got to be ENT. And I was able to confirm that I liked the people, I felt like I fit in. I got to talk to people about what the lifestyle of a resident and what the lifestyle of an attending is. I found a good mentor, and all those things made it a lot easier for me going forward. But I didn't do so well on step one. So um, I was pretty sure that I wanted to do ENT. I wasn't 100% positive, and I knew that I was going to struggle a little bit in the application process for the match because of that score. And so the combination of those things and a bit of privilege that I was able to do this, I was actually able to do a research year between my third and fourth year of medical school. So before applying to residency at all, I decided to take a year to do research. And that research actually ended up being in voice at the NYU Voice Center and also at Columbia as well. And I was able to get a lot of amazing experiences, both clinical and research. And it completely and totally shaped where I am and where I see myself going. And I still talk to my mentors from my research year like at least once a month, if not more. So those relationships don't go away just because you've moved on to the next step. Um, there is always a next step, and it's a pattern that I've noticed in myself and other medical professionals that it's a bit of a treadmill and it just keeps going. So remembering that, I saw something on Instagram the other day that was basically like, remember that where you are now is where you wished you would be when you 5 years ago. And so I think that it's easy just to think about the next hurdle. But remember that, where I am now is someplace that when I was in undergrad, I would be ecstatic. So even if I'm feeling overwhelmed or frustrated or nervous, if I think back, I realize that each hurdle you get there, and it's good to look back and remember why you're there and what motivated you to get there in the first place. So the match process I won't get into. I feel like that's a little bit beyond this discussion, but I'm happy to answer any questions about that. Just to say that ENT is a little bit more competitive than some other specialties. There's fewer spots, and it's a pretty good specialty as far as lifestyle and well, I think it's the best, but I'm I'm biased, and so it is a little bit more competitive. So that goes into well, I'll talk about it a little bit later, but sort of ways to optimize your path. Um, but I ended up going to University of Cincinnati for residency, which was a great experience. I really got amazing training, and I think that in the ENT community, it's very well regarded. It's probably not someplace that anyone on here has ever even heard of, but each specialty and each community has its own hierarchy, its own um, ways of evaluating programs. And the further along you get, the less people remember where you went to undergrad or even, like I said, know what your score was on step one. I don't even remember at this point. So University of Cincinnati was amazing. And I was able to continue a lot of the relationships that I had made during medical school and then create many more within the field of ENT in general. And then I found that all of my favorite mentors, not all of them, but many of my favorite mentors were within a field called laryngology. So ENT is a very broad field. It goes from sinus surgery to cochlear implant ear surgery to big open airway surgeries to, it's a hugely varied field. And you can choose to go on and do a fellowship within ENT, just like many other specialties. There are, I think, 6 or 7 different fellowships that you can do at this point. One of which is laryngology, which is the one that I ended up choosing. The process for applying to fellowship is a lot less stressful than applying to medical school and a lot less stressful than applying to residency, and is a lot more about your passion for the subject and your plan for the future. So you go into your fellowship interviews knowing why you want to do a fellowship in the first place, because it's not required, and having sort of a vision for what you want to get out of it. So I ended up at a very cool fellowship, and that's where I am right now. I'm just finishing my first year. It's actually the only 2-year laryngology fellowship in the country. And the reason it's 2 years is because it integrates a master's degree in essentially clinical research. What I'm learning is all the stuff that I probably should have learned even in undergrad when I was doing research, basic biostatistics and study design and learning about clinical trials and grants and all of these things that help make you successful as a researcher that I've sort of been learning piecemeal all along, but knowing that I want to do that in my future career as a laryngologist, this fellowship is giving me the opportunity to really solidify that background knowledge. Um, there are actually quite a few opportunities for degrees like this, including business degrees, public health degrees, research certificates. There are a few medical students in my program that are doing a one-year version of what I'm doing during their essentially research year. And I think that seeking out those opportunities can not only make you more excited about a topic, but also make you a more well-rounded candidate for future positions. So definitely something to think about as you think about where to spend your time and what your long-term trajectory is. You know, if you want to be a researcher, find a way to get the skills that you need to do high quality, good research. My process for doing research is going to be a lot easier now that I really know what I'm doing and I'm not sort of fumbling my way through. So I think that that's something that I didn't really realize was an opportunity back when I was pre-med in medical school or in undergrad, but is something to keep an eye out for. There's a lot of really amazing opportunities, the one-year programs, part-time programs, and if you're doing it during training, a lot of times you can figure out a way to get your employer or program to pay for it. So um, or get funded through like the NIH or something. So my program is fully funded. I don't have to pay for the master's. It's part of the Clinical and Translational Science Center here at Cornell. So it's a really amazing program. And I really would encourage anybody who has an interest in academics or in public health or in the business of medicine to seek out these types of extracurricular curricular programs, if that makes sense. So laryngology is the fellowship that I chose. We already kind of talked about how I ended up there and how that process works. But just to say that there are a lot of different paths to go to. So my particular path is a specialty that focuses on airway, swallowing, and voice. So this is a pretty neat picture or video in the middle here. This is a high speed image of the vocal cords during phonation, during talking. And you can see that there's a lot more motion, a lot more physics, and a lot more anatomy and physiology that's involved in something that we don't even think about, that we take for granted. And I think it's really cool. I suppose that's a good thing considering that's what I'm focusing on. On the right-hand side is a video, it looks like it's stopped playing now, but of what's called an MBS, or a modified barium swallow. It's a radiologic exam that evaluates the process of a patient's swallow. So you can see whether they're aspirating or if they're having trouble moving the food from the front of the mouth to the back of the mouth. There's all sorts of things that have to happen in order for your food to get from your lips down into your stomach. And that's something that we focus on as well. And then the picture on the left is a trachea and a larynx, which anything can happen within that. You can get a lot of things can go wrong, and some of my cases that I have ready for you will address that. So the first one case that unless people want to stop and ask questions right now, I can keep going. But the first one is a case of a guy who is an older gentleman. He was having trouble swallowing. He comes in, he says, I just can't get stuff to go down. And sometimes like it'll come back up later, like my pills, like an hour later, I'll cough and they'll come up, and really having a lot of trouble, starting to lose some weight, and having a lot of difficulty with swallowing. So I'm going to try and play this video. It tends to glitch out, so bear with me. I hope it works. We'll see here. And you'll probably hear me. My voice sounds very weird to me, but to you, hopefully it'll sound the same. Not working. There we are. Okay.
All right, and swallow.
What I just asked him to do was to bear down or act like he was having a bowel movement. So that's called the Volsulva Maneuver. So you kind of go, and you saw that there was some fluid that came right back up. So can you see my arrow here? Are you able to see the arrow on the screen?
Yes.
Awesome. So this is what's called your epiglottis. Back here is where your esophagus is, and the vocal cords are underneath this schmutz here. So you'll see he's going to do it again if I can get the video to run correctly, and you'll see as he bears down that that will come up again. So let's see if it works.
While I'm doing that?
Well, no, you can swallow now.
Okay.
Of course, it's not going to work now, but
You want to
Do it again.
Do the bowel movement?
it's
Yeah.
a very impressive video.
Hi, doctor.
Excellent.
Yes.
Do you mind minimizing the screen on the side? Because I feel like students might have difficulty looking at the.
Minimizing the
You
screen
can,
on the side.
yeah. So the camera, are. I think people might have difficulty looking at the slides. If you can press the minimize button on the side.
Minimize.
No,
Okay.
no, it should be on our pictures. Sorry.
Did that work?
Yeah, I think that's better.
Oh, because you're seeing these videos.
Yeah.
I see. Okay. I see what you're saying. Okay. So is that better or not? Here, let's do that.
Yeah, that might be better. Yeah.
Okay. So basically what happens is this material pools up as he bears down. I apologize that video didn't quite come through, but when we did a barium swallow, which you saw a picture of earlier, we see this little pocket here. So the normal esophagus is this part in the front. So this is the back, the spine. This is the front, the chin is up here. And the normal esophagus is this front part here. But as you can see, there's this nice pocket. That's called a diverticulum, or Zenker's in this case, diverticulum. So it's a little outpouching of the esophagus. And that's something that we as ENTs and as laryngologists treat. We can treat it a few different ways. Through the mouth, actually without making any incisions in the neck, we're able to sort of cut that partition between that pocket and the normal esophagus and allow food to pass through. In this case, we weren't able to get that access. Sometimes when a patient can't put their head back, or if they have a small mouth opening, it can be difficult to get that view. And in that case, you can also do the same surgery through the neck, which is very cool. To be able to approach a problem in many different ways. So for this particular patient, we were able to split that dividing wall. I won't go into too many details, but open up that pocket and allow food to pass freely through the esophagus. And you can see here, now there's no pocket left. And so that was pretty exciting. Patient was able to start gaining weight, wasn't having any more problems with swallowing his pills or any solid food at all. Very exciting. The next case that I wanted to present is a case of transgender voice care. So it's kind of a hot button topic right now politically, but we won't get into that. But just to know that laryngologists can play a big role in the process. This patient here is a 23-year-old transgender woman who has spent many years in the transitioning process and, just hasn't been able to get her voice to do what she wants to do despite years of training and treatment, and frequently gets misgendered as a man on the phone and feels that what's called her fundamental frequency or her pitch is too low, and wants the pitch to be higher. So this is a tuning fork here. It simulates what happens with the vocal cords. The faster the tuning fork vibrates, the higher the pitch, or the faster the vocal folds vibrate, the higher the pitch. And the length of the vocal cords also matters. So for this patient, we were able to do a surgery. It's called a Wendler glottoplasty, which is not important. But basically, we took her normal vocal cord length and shortened it by essentially cutting out the front half of her vocal cords and made her vocal cords shorter, more similar to a XX female's voice box, the length of the vocal cords. So I'm going to actually, so this is what it looks like after it heals. You can see that the length of the vocal cord, which would normally go from here all the way to the anterior edge, gets shortened, and they have smaller vocal cords. So I have an example. I'm going to see if I can X out of this. And let me know if you can't hear this. Hasn't started yet.
When the sunlight strikes raindrops in the air, they act as a prism and form a rainbow. The rainbow is the division of white light into many beautiful colors. These take the shape of a long round arch with its path high above and its two ends apparently beyond the horizon. When the sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors. These take the shape of a long round arch with its path high above and two ends apparently beyond the horizon.
So it's pretty impressive, the difference that you can make in somebody's life through what is actually a relatively minor procedure. So that's pretty exciting. I thought that was a pretty fun, interesting example of something that's unique in our field. I do have two more cases. I called this one the Fauci ouchie. It's not actually Dr. Fauci's vocal cords, but as everyone knows, he had what's called a vocal cord polyp and did have to get a procedure done to remove that. His procedure was actually done in the operating room under general anesthesia, but you'll see this patient, which is a made-up patient, it's not a real patient, was able to get a in-office procedure. So that part of it is real. I'll show you the pre-video so you can see what it looked like pre, and then we'll show you the post. This one I think will work. So what you're seeing is at the bottom of the screen is the front of the voice box, and those are the vocal cords that are supposed to be vibrating, but obviously there's a mass on top of the vocal cord or on the vocal cord. That's called a polyp. So the vocal cords can't vibrate. The voice is very rough, really not comfortable to use, and can't project, has a very rough quality to it, as we all heard in our dear Dr. Fauci's voice during the process of the last year. So we were able to do an in-office procedure while the patient's awake, sitting right in our office. We numb their voice box and we use a laser, and we're able to actually treat this polyp, which is really cool. I'll show you a video here. You'll see flashes of green light. It's a green light laser. It's called a Ktp laser. So if you know anything about lasers, I don't know if any of you guys are physicists, but what's called the chemophore, or the thing that it targets, is red or blood. So you'll see here, it actually will target the polyp that we're looking at. And those are the flashes. The video doesn't capture it because it's very bright. And so on and so forth. And we keep doing this, and this patient is completely awake, sitting in the office, looking at us, cooperating with us. We're able to give him more anesthesia if he needs it. Just fast forwarded to another part of the process. That is actually only about 2 or 3 drops of blood. It just looks very blown up here in this picture. So what we'll see then is what it looked like afterward. This is after a few, I think a month and a half of healing. And this is what he looked like.
Push more air. Good, breathe. Higher pitch.
So yeah, as you could see before, he's completely unable to do that pitch. You can see that big Goomba is completely gone, and all of this was done in one office procedure. So pretty neat and pretty exciting. A lot of laryngology can be done right in the office, which is really beneficial for patients and has been great during COVID because we haven't had access to the operating rooms. The last case I wanted to talk about actually has to do with COVID. So this is it's not a real patient again, but it's a story of many of the patients that we've seen. And basically a woman who had been intubated for COVID for many weeks and ended up getting scarring of the airway just below the vocal cords, to the point that it actually scarred closed. So she had what's called a tracheostomy, or a breathing tube in her neck, and wasn't able to talk. This is all like basically she got intubated at the beginning of COVID, and we saw her a few months ago and hadn't been able to talk since she got sick, hadn't been able to breathe without that breathing tube in her neck since she got sick. She'd had tons of procedures to try and open it up, and none of them had worked. So we did what's called a cricotracheal resection, which is a fancy way of saying we basically cut out the bad parts and hooked it back together. It's simple in concept, it's difficult in practice, and it's quite a process for the patient, but it was pretty amazing. We went to go see this particular patient the day after surgery, and she spoke for the first time in 12 months, 9 months, 12 months, something like that. And, started crying and was able to say thank you. And she didn't have a breathing tube in her neck. She didn't have a breathing tube in her mouth. And it was really powerful and really neat experience, and something that has become more and more prevalent right now with all of the stuff that's been happening with COVID. So things change depending on the world stage as well within your field, and you adjust, and the surgeries adjust to meet that need. So this is just a little more information about that surgery. Basically, it's used to open up the airway below the vocal cords. A lot of times we can do things endoscopically, but at some point you just have to do a big open procedure. Open meaning through an incision. So this is before and after, which I thought was pretty impressive, so I had to put that in there. So I guess that the point of me showing all of these types of cases is really to say that laryngology for me is different every single day. Not only am I doing the research and the master's education stuff, but really my day-to-day goes from seeing a performer with a tickle in their throat to seeing a patient with a really bad cancer that needs to be taken out. And I think that finding a field that fits what you like is really important. But for me, I don't like to be doing the same thing every day. So for me, choosing a field where I got to see a variety of different types of patients, I can see kids, I can see adults, I can do things in the clinic, I can do big open procedures in the operating room. Having that variety was a very important part of my choice of what specialty to do. And that's true of ENT at large, as I said before, but also within the field of laryngology. So I can, start out by doing a bunch of big airway procedures in my practice. And, when I get old and tired, maybe I'll just do some in-office, injections and not do big operations, but I can make that decision throughout my career. And I think that that's really exciting as you start to think about what direction you want to go in. So advice for pre-meds. I had to think back a little bit. But one thing that I thought about, I actually was just talking to a friend about this, was if you prepare for the hardest path, then if you do something easier, you'll already have the work done. So I didn't know if I was going to go to medical school, but I started doing the legwork thinking, well, if I do have to go to medical school, at least I've got that done, meaning the coursework and the prerequisites. And the same went for ENT. I wasn't sure I wanted to do ENT, but of the things I was interested in, it was the hardest on the list. And so I did everything I could to optimize myself as an applicant for that process, and knowing that if I decided not to do ENT, I would still be prepared and have a lot of experience to do whatever I ended up choosing. Starting early is always a good thing. I feel like that's a dangerous thing to tell pre-meds, having been one myself, because we tend to take that a little too far. But it does make life easier if you start making those connections early. And certainly I've benefited from having early connections within laryngology specifically. So I think that starting early is nice, but it's not necessary. And then I think I've said this a few times now, but doing what excites you. If you're not excited about something, you're not going to do your best work. So, don't force yourself or convince yourself to do something because you think you're supposed to do it. Find something that really gets you going. And it's not going to be every day. I don't like going to work every day, but big picture, I'm right where I want to be. And that means that I work hard and it doesn't feel like I'm working hard, So I think that if you find an area, be it medicine, public health, uh, research that you really love, it'll be much easier to be productive and proceed through your process. So that's sort of what I had prepared. I'm happy to answer any questions. I do have social media accounts where I post some stuff, but it's nothing crazy, nothing too extensive. So I'm happy to answer questions now or at any time, really, if you have them.
I had a question for the second case with the, the third case with the lump in the throat. Was it the vocal cord?
Mm-hmm.
Did you guys just take it out of the vocal cord, or did you guys I know you said you use lasers to break it apart.
Yeah, so the interesting thing about the laser that we use is that because it targets red, it targets the blood supply of the growth. So that's what's called a hemorrhagic polyp. So it basically forms because of a little bleed that creates a little nodule on the vocal cord, a little polyp on the vocal cord. So by cutting off the blood supply using the laser, it actually sloughs off, which sounds really gross, but it's really about the size of, I don't even know, like a grain of salt, a hefty grain of salt, like kosher salt. But it's not very big. So, they cough it up or swallow it, or they don't really notice, and it does slough off on its own. We can remove them in the office too. So we do biopsies and things like that in the office, but we find that the effect on the vocal cord, as far as the vibration and the ultimate outcome for voice, is better if you can leave as much behind as possible. So you want to take only the unhealthy parts. So the laser's been pretty impressive for that. And we're actually studying that in our group right now, looking at whether normally we would do that kind of case in the operating room, but with COVID, we haven't been able to. So we're actually studying whether or not the outcomes are different, or if doing the in-office is just as good. And I can tell you from my 1 year of doing this that it's very impressive how it turns out. So that's exciting.
And have you seen any tumor growth in the vocal cord?
Absolutely. So larynx cancer, it's the prevalence is going down because the prevalence of smoking is going down, but it's still very common. And a lot of times the laryngologist or the voice specialist is the first one who sees it, because they have a scratchy voice, and we're able to look down with our cameras. We look at every single patient who comes into our office. We look at their vocal cords, and we're able to see it. And if it's early, sometimes even if it's cancer, all we need to do is laser it, which is very exciting, because there are patients that if their tumors progress really far, you actually have to take their whole voice box out. I've done several of those this year too. It's always heartbreaking as somebody who specializes in the larynx to remove a larynx, but it is a life-saving surgery. This is maybe not the right way to say it, but the good thing about larynx cancer from an ENT perspective is that it is a very surgical disease. So we're able to help patients by doing surgery, which isn't the case for all cancers. Lymphomas and things like that, you don't cure lymphoma with surgery, you cure it with chemotherapy and radiation. So, larynx cancer is one of those things that we can really have a big effect. Have we noticed an increase in patients that use nicotine vape pens? So there is no research, is the short answer. There's certainly a increased prevalence of irritation that we've seen in young people who have hoarseness or a cough or something that's related to the irritation of using the vape pens. Personally, I think probably it's less carcinogenic, meaning less cancer causing than cigarettes, but I have no evidence to support that. It's just a feeling of what the substances that they're using are. I did a paper like many years ago when I was in medical school looking at what research was out there at that time, which is very out of date now. But at the time, they looked at what chemicals were actually in the vapor compared to cigarette smoke, and there were much fewer nasty chemicals in it. That being said, I wouldn't do it because it can still damage your voice and lungs in many other ways. So if you can avoid that, I would. And the same question goes for marijuana as well. It was just legalized in New York. And the advice I give my patients is you do you. I would use an edible more than smoking because the irritation on your voice box is going to be worse. So if that's something that you're going to choose to do, try to do it in the way that will be the healthiest for you. Typical day for me, right now, I would say a typical day on a clinic day, we would see a patient about every half hour. And we're scoping every patient and looking at their vocal cords. And we have clinic 4 days a week usually. We're in the operating room 3 to 4 days a month. So on an operating room day, if you're doing smaller cases, you can do 5 or 6 cases in a row. Lots of endoscopic stuff, so stuff through the mouth that we do in the operating room, including really fragile microsurgery for vocal cords, even on performers, which I'm sure you guys have heard, like Adele and people like that had little things removed from their vocal cords. So that's the type of surgery that I am getting trained in. And then, if we're doing big cases, like that big airway case, we just have the one case, and that case lasted from 7:30 in the morning until about 2 to 3 in the afternoon. But sometimes they can be longer, sometimes they can be shorter. There's a lot of variation in the day, but I would say ENT is more clinical than operative when you compare it to other surgical specialties. So ortho, I would say you're in the OR on average more than you are in ENT. But we're in the operating room probably more than most ophthalmologists. So it's kind of a continuum. Looking back on my medical career, is there anything I would have done differently? I think that it's easy to say because hindsight's 2020, but I would have worried less about each little part of my applications in each step and realized that it is a big picture, holistic view more than I realized. I think I was pretty good about optimizing personal relationships, but I think that I wish that I would have realized that was as important as it was. Other things as far as training that I would have done differently, I've pretty much been really lucky and have ended up exactly where I want to be. So I feel very fortunate. I think that I don't think I would have done anything like big career branching decision wise differently. As far as the male dominated field, it is definitely a male dominated field, ENT. Laryngology in the generations above me were almost exclusively men. But in the generation right above me, where a few of my mentors were, I think the balance of male to female tips in the favor of women. ENT is still pretty backwards as far as how it deals with trainees and family planning and all of that, just like every surgical residency is, but it's getting better. And there's a lot more representation, both gender and diversity, socioeconomic and racial diversity, that is coming, and it's getting better, but it's definitely got a long way to go. We are not nearly where we should be compared to other specialties and definitely other fields. So I think that as women, I'm very small. You guys can't tell from here, but I'm about 4'10" and blonde. And when I walk into a room, people don't think surgeon. So I do. I was asked before you guys got on, would you rather be called Dr. Bourne, Dr. Hayley? When I'm amongst people that I'm just talking to, I go by Hayley, but certainly with patients and colleagues in the hospital, I'm always introducing myself as Dr. Bourne. Not so much because I feel like I need to show off that I'm a doctor or assert my dominance or anything like that, but just because the assumption is not there and I want to make sure people know what perspective I'm coming from. So I think that that's something that I have done a little bit differently than my male colleagues. You'll see going forward in medicine that you'll be guided in different directions depending on your background, gender, racial, socioeconomic, and you'll be pushed to go in different directions. My advice to you would be to find somebody who you trust or who looks and feels like you, that does what you think you want to do, and talk to them about how they overcame whatever it is that you feel like you're trying to overcome. The people above you are going to have the best advice. What would I recommend doing when someone feels overwhelmed and doubtful about being accepted into medical school? Uh, so I would embrace it and say that every single person, no matter how qualified they are, feels that way. The way that pre-meds and type A people in general can mitigate some of those feelings is to be as prepared as possible. So when I said start early, prepare for the hardest thing, that's sort of what I meant. Like, the way I looked at it when I ended up in each level of applications was, did I do everything I could have done to get into X, Y, or Z? Medical school, residency, fellowship. And as long as I felt like I did everything I could, then there was a certain zen about it. But I can tell you that every single pre-medical student, every single residency applicant, every single fellowship applicant has those feelings. And talking to other people about it can be helpful. I would not go on Student Doctor or whatever the equivalent is now. I don't know if that still exists, but man, the people on there were so neurotic, and it just fed into that anxiety. And you'll go on there, but just try to at least remember that you're seeing a very small portion of the population at a very specific time in their lives. So don't let anything that's on those types of websites, of which there's one for every specialty as well, really affect your life outlook, because they can be very unhelpful. There was one for ENT called Otomatch, and I tried to just go on there to find the useful things, because they had, like, charts of the different programs and timelines and things like that, which were useful. But I really tried to steer clear of the chat boxes. Definitely.
Well, thank you so much, Dr. Hayley, for taking time out of your busy schedule.
Of course. And if anyone has any questions, like I said, these are my accounts, and you're more than welcome to DM me or anything like that. I'm happy to answer. And if I don't know the answer, I'll at least point you in the right direction.
Yeah, thanks again.
Thanks, guys. See ya.
Okay. For those of you who are currently attending, we have posted a form. We should post a form on the chat box. So make sure to take the assessment and receive more than 70% to receive credit for this session. And please try to use one email throughout all the sessions so we can track your hours. And our next session will be on, give me one sec, April 23rd with Dr. Majid Isreb, who's a physician in nephrology. So stay tuned for that. And again, thank you for participating, and take care.